Morning, everyone. I would like to thank AIOC and Dr. Subhashini, our chief instructor, for having me. So let's see, like, how should we deal with the failing bleb? Slides are not moving. So, as we all know, trabeculectomy, doing a good trabeculectomy is just the 50% of the job done, and the mic is also on. It's on. Okay. So it's just the 50% of the job done, and the rest of the process is like achieving a successful trabeculectomy depends much on the post-operative management. It is often called as an art rather than a science. Hence, it is very important to plan a meticulous follow-up for getting a successful bleb. So, what are all the features of a successful bleb? So, it will be quiet and it will be like diffuse, elevated, and it will not be totally avascular. There will be paucity of the vessels, and of course, we'll have an appropriate IOP control. So, wound healing is definitely it's a challenging process here. When there is excessive healing, there is a closure of the filter, and when there is like incomplete healing, as highlighted by Dr. Subhashini, we'll be having complications associated with the hypotony and the flat AC, which is also vision threatening. So it is very important to have a good follow-up protocol. Unlike cataract surgeries, where we do the surgery, send the patient and see them after 3 weeks or a month or so, here it is very important to plan a meticulous follow-up. The first visit should be on the post-operative day 1 and then see bi-weekly. When you see the patient like 15 days after the first the post-operative visit, we have to assess the bleb morphology and decide on further follow-up visits. If the IOP is adequately controlled at the end of second month, we need to insist the patient that they should not think that they have undergone a surgery, and some of the patients will think that that's secure and they will stop following up. And as we saw highlighted by my previous speakers, there can be late complications related to the bleb, and hence it is very important to educate them the need for post-operative follow-up even after like months together after a trabeculectomy to prevent late complications. So how should we identify a failing bleb? So it can be either a flat bleb with this highly vascularized with a thickened surface, and sometimes it can be highly dome shaped and angry looking blebs which is localized, which is tenon cyst. So the framework for the classification of this failing blebs, it can be based on the intraocular pressure and also based on the bleb morphology. It based on the intraocular pressure, it can be a high and also it can be a low pressure also. So the low pressure is already been dealt by Dr. Subhashini, and based on the bleb morphology, again it can be either a flat or a low bleb, or it can be a high bleb. So this is an example. This shows the ring of steel, which was more common when people were doing a limbal based flap and conjunctival flap. Now it is like less common, as most of us we have moved to a phonics based conjunctival flap. So the most common reasons for the external or the failure include the subconjunctival or the episcleral fibrosis. There can be the subscleral fibrosis, or it can be just tight scleral flap sutures. And the internal causes can be the ostium can be blocked either by the vitreous or by a fibrin membrane because of the inflammation, and sometimes we can see the iris getting picked up and blocking the ostium whatever we created. Here we can see is an encapsulated bleb or tenon cyst, which is like a highly dome shaped, elevated and no angry looking blebs. How should we approach? So it's very important to intensify the dose of the corticosteroids, the topical steroids, whatever we do, and then we should try doing a digital massage, consider a suturolysis, consider subconjunctival injections of the antimetabolites, and last, if it is nothing is helping, we can consider a bleb needling. So unlike the cataract surgeries where we routinely give steroids only for a couple of weeks or 3 weeks or 4 weeks, here it's like usually it is given up to 2 to 3 months depending upon like your own post-operative protocol, because it decreases the wound healing and and reduces the chances of scarring, and it helps us to maintain the fistula whatever we created during trabeculectomy to remain open. So most of the time it is used up to the period of 3 months. So it's very important to do assess the cause of the trabeculectomy failure when the pressure is high, when the chamber is also formed. Here we can see typically the iris is peaking up, and you can see the iris blocking the ostium whatever we have created. So it's very important to do a gentle gonioscopy to fix the cause. And the next is very important and very useful tip is to do an ocular massage, digital massage. It can be done either through the lower lid or it can be done through the upper lid. When we do through the upper lid, we should make sure we are doing much beyond or behind the flap area, so that the pressure whatever we are giving, it will push open, the aqueous will push open the scleral flap and the bleb will form. So we have to remember the initial conjunctival apposition after the trabeculectomy, it has to be really watertight. Unless until the aqueous gets collected in the subconjunctival space, the adhesions will start forming and the episcleral or the subconjunctival fibrosis will happen, which is the most important cause of bleb failure. So when we do the digital massage, we can very well see that it induces the aqueous to get collected in the subconjunctival space, and hence it prevents the failure. So this is a small video demonstrating the digital massage. You can see there is a flat bleb. As I just pressed behind the scleral flap, you can see the bleb is getting beautifully elevated. The next, if it is not helping, then we can think of suturolysis. And the suturolysis, we have to remember when we have multiple sutures, it's very important to avoid lysing all the sutures at a time, not more than one suture at a time. And if you have 3 sutures, you can think of select the suture based on the bleb elevation with the digital massage. Wherever you feel like the aqueous is not percolating, the suture is tight, like you can release that suture. Hoskins lens can be used, and the energy settings are shown here. And when we use mitomycin, which is of course a routine by most of us, it is very important to delay the suturolysis at least for 2 to 3 weeks. This is how intact suture looks like, and this is how you can see a space here. The live suture will look like. So in case when preoperatively we know that like a young patient or a traumatic glaucoma or a juvenile glaucoma, where a patient will have a thick Tenon's tissue or inflamed eye, where there is, or otherwise if you don't have access to laser, we can think of using a releasable suture. We can see here in the video, it was demonstrating how the suture was removed, and after the suture removal, just again try the gentle massage, the blood will rise, and we can consider giving injections of 5-fluorouracil. Now people have totally shifted to mitomycin C injections, either with or without blood needling. But in my experience, I don't give mitomycin C injections without blood needling. But this 5-FU is like, though less potent, can be safely injected in case if you are not successful with suturolysis. And the last resort is like blood needling. Before we say that we are done with the things, here we can see a small localized and highly vascularized bleb. Here we can use 25 or 26 gauge needle, and some people might use MBR blade also. So just putting a drop of adrenaline, like cotton tipped applicator, can be applied over the area. A corneal traction suture is applied for a better visualization. I'm using a 26 gauge needle and bending it, and we have to enter much away from the area of the bleb, and we have to make sure we keep the bevel up, and just small sweeping motions. And as we keep advancing, we can see here as we keep advancing, at some point of time we can see the bleb will get elevated, and it's very important not to enter directly over the area of the flap, or otherwise we will create a leaky bleb that is more painful than that. At the conclusion of the procedure, we can give either injections of the 5-fluorouracil, or we can even give the injections of mitomycin C, and we have to make sure we are giving much away from the bleb, 180 degree away from the bleb, because if you inject closer to the bleb, there is a chances of the drug getting entering into the anterior chamber, and we will land up in bad complications. This is whatever I am demonstrating here is so we can see here now bleb is beautifully getting elevated here. So this is the procedure for at the end of the procedure, definitely the eyeball will be soft, and we have to make sure that we follow up the patients post-operatively. And there are factors which are showing the first post-operative day IOP is a big determinant of the success of the bleb needling, and also the blebs which have been functioning for some time when you do needling, so the chances of success are higher than a bleb which has never functioned. And there are articles which have shown that MMC is like more potent than a 5-fluorouracil for these procedures. And this is a paper from one of our Arvind branches, like where they have evaluated the outcomes of bleb needling in a prospective way. And here, as you can see, they have given injections of 0.2 milligram per ml of MMC. The complete success in these patients who had either a TRAB or a combined surgery was 37.9%, and the qualified success was 53%. And of course, in this paper, younger age was a risk factor. So when to stop? So we need to know when to stop. It's, as I said, it's just the beginning of a whole process. It aims to achieve satisfactory bleb morphology. It really takes sometimes months together. Despite close monitoring and no often intensive follow-up and treatment and intervention, some blebs or trabeculectomy is destined to fail. And further interventions like available include it as a medication or the revision of the TRAB or a GDD or a diode. And now we have the options of considering mix in this eyes also. And this is an article where we have discussed about the wound modulation in the glaucoma surgery and the role of anti-scarring agents, which discusses about the role of antimetabolites in all the available glaucoma surgeries. Thanks for the opportunity.
Thank you, Dr. Kavitha. Thanks for those excellent tips.